We have like 400 so far attendees.
Can you see now?
Yeah,
Yes.
it's shown now. It's shown now. Yeah. Can you
Yes,
just open screen? Open it.
Can you see it now?
Yeah,
We can see your screen now. Just
you put it in a presentation mode, please. So
it's on a presentation mode.
oh, why I not see
It's
the
a
full
slide.
Yeah. Just enlarge the slide. Just do your presentation. Start it in a
It's
presentation
not. It's not enlarged in your side.
No. In our screen, it's showing like a small size with the.
Because in my screen shows the big size.
Okay, maybe you need to reshare it again. Maybe it will show, please.
Yeah, you have to click that button on the right of your screen to make the slides taking the full length of your laptop monitor.
Can you see?
Yeah, we see your desktop now. It's your desktop.
You see my desktop. Okay,
yeah.
so
Yes, open your presentation now. Yes.
It's open. You see it
yes.
now. Okay.
Yes, it's open, but it's not in a show.
Yes, now it's
that's
now
perfect.
Now perfect.
Now
Okay.
I think we have to start.
That's right.
Okay, perfect. We will start now.
When you give me the start, and I'll do that.
Yeah, I'm starting. I'll do the introduction.
Okay.
بسم الله الرحمن الرحيم والصلاة على أشرف المرسلين سيدنا محمد وعلى آله وأصحابه أجمعين. Dear colleagues, dear Professor Zoe Valmaki, Professor of Breast Oncoplastic Surgery, dear panelists, Dr. Ihab Saad, Dr. Amr Safwat, Dr. Islam Khalid, and Dr. Dina Nabil. I would like to welcome you to our webinar today. On behalf of Saudi German Hospital Group, I would like to welcome all of you, and welcome our participants for our webinar series with international visiting professors. Today we will discuss important subject for many of our colleague physician and surgeon and our patients about breast cancer care. With a new approach to treatment and to the care of breast cancer involving multidisciplinary team. I would like now to give the floor to Dr. Ihab Saad, General and Oncosurgery Consultant and Professor of Oncology, Oncosurgery, and Chief Medical Officer of Saudi German Hospital Jeddah and Head of General Surgery Department to start our webinar today. Please, Dr. Ihab.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. I'd like to welcome you all in this webinar. I believe it will be very fruitful. We have today one of the very eminent name in the breast oncoplastic surgery all over the world. It's an honor and pleasure to welcome Professor Zoe with us today. Professor Zoe have been completed her advanced breast and reconstructive oncoplastic surgery in Boston 2004. She had more than 20 years experience in that field with more than 10,000 operations of that kind of very special approach. I believe all of us, we will benefit from her experience, and we will take a lot of information about the recent advances and recent technology in breast oncoplastic surgery and recent approach. I'll leave the platform now to Professor Zoe to start her presentation. After presentation of Professor Zoe, we will have about 15 minutes with Professor Dina about pain and management of pain post-mastectomy and how to deal with it. Now it's time to welcome Professor Zoe. It's yours, Professor Zoe.
Thank you all. Thank you for having me with your company and your participation in this wonderful meeting that you organized about the subject that is deep in my heart. I've been working more than the time you just mentioned. Thank you all. Thank you, Dr. Ihab. Thank you, Dr. Dina and Dr. Amra and Dr. Isham and Dr. Yasser. I apologize for my accent towards your names. I'm not familiar very much with your difficult names sometimes.
Yes, sir. Yes. Welcome. Thank you.
Thank you very much. Today I'll take you through how we look at the breast cancer and what we do. The breast cancer has enormous steps of progress in the last few years, and this is not just a progress of one science. Breast cancer is multidisciplinary work, and a lot of sciences come together to put the efforts and progress the breast cancer treatment in the last 20 years enormously, that we have the results and confidence to say to our patients that nowadays we can diagnose early the breast cancer and treat the breast cancer, and take the panic and anxiety that a lot of times they get and afraid to come to the hospital to discuss their problem. Especially nowadays after the experience of COVID-19 everywhere. It's a global crisis that has affected also women who suffer of cancer, any patients, cancer patients, but also the breast cancer patients. We have to reassure them that we continue their treatment and their care, and they should not hesitate to come and talk to us and their problems. Now, as I said, the breast cancer is a multidisciplinary work. We cannot achieve what we achieved so far if we don't have all these specialties together. At all times they work together. To organize the breast diagnosis, you have to organize a team with your radiologist, who is the first hand as soon as the patient comes into your clinic, to organize the imaging after the clinical assessment, and take it forward with the pathologies if the biopsy is needed, and later on with the treatments that could be organized as surgical treatments or adjuvant treatments or radiotherapy and on. Apart from all these sciences, very important role they play also the breast care nurses in a setting of a teamwork. Breast care nurses part of the work that we do to help the women get those steps that of treatment that they are involved, and overcome the anxiety and get to. It's like a marathon that we have to train them. It's a fact that nobody wants to be diagnosed with the breast cancer. It's a time that they have to put forward, work all as a family, but part of that family, we are as a team, the team of doctors we are part of her family, the woman's family or the man's family, to take her forward and overcome the stress and anxiety, and keep the positive attitude, because it's very important for a woman to have that positive attitude and overcome and go through the treatments. Now, how the breast diagnosis, the breast diagnosis. As you know, we have the screening group of patients that, since we organize screening, we have seen enormous an increase in number of breast cancers, but also we have increased the number of survivors. From the year we apply the screening, although you see that the screening has improved the survival up to 30%, maybe more, still we see more diagnosis, because the tools we provide from any specialty help us to diagnose small tumors, small invasive tumors. So women, if they come to talk to us, we have the tools to help them and diagnose their problem if there is one. Now, after COVID-19, things have changed a little bit in view of the screening, and we invite most of the women to come asymptomatic and as emergency, and to postpone a little bit until we put things back together to where it was. It's the after COVID-19 normal that we need to adjust to. So the symptomatic, patients comes in the symptomatic group, in the symptomatic setting, that your clinic has to be organized. And as the first step, once the patient comes in with a symptom, to see the breast surgeon, the breast specialist doctor, then will be organized to see the radiologist and do the imaging that is organized appropriately. If they need to do for a biopsy, we like to do that triple assessment, as we call it, in one visit. And that's, of course, another successful achievement to a successful team to offer the whole full service to a patient in one go. So if you have a team that is well organized and specialized for the breast disease and breast cancer, then you can do all that in one day and have an answer to your patient in once the result of histology, if the histology need to be done on the same time later on in, with another follow-up review. Now, as first tools of investigation, we have the mammograms and ultrasound. All depends on the age of the patient. Age is another factor that you have to depends on what investigations you need to arrange first. And as the women under the age of 40, we intend to organize them as a first step with the ultrasound, and after the age of 40, we organize for the mammogram. Of course, if there is a problem from the ultrasound or the symptomatic for the clinical examination, then we can organize other modalities, other investigations. So we have the MRI that we don't need as a first step to do the MRI, but only in patients that are calculated to have a high risk. And one of that is when they have a genetic testing that is the genes, as we call it, positive, or if you have a breast that is very dense and it's impossible to diagnose, but the symptoms are contradictory to what you look, or if there is a controversy between ultrasound, one ultrasound says one thing and the mammogram another thing, you need to do another test to just put a balance there and find the result. So you have the options to choose what is the best first step of investigations to offer to your patient. Now, we all know a little bit of the risk factors of the risk risk factors that of breast cancer. More or less, most of the doctors and most of the people come to understand with the media, they hear about it, a lot of information is out. One of the things that I like to underline in this case, we have the family history of breast cancer, and we know two of the genes that we or more started in the beginning. It's breast cancer 1, breast cancer 2, but on the way from the time we found those two genes, by now we have another number of genes that we have identified. And there is the gene variant that they exist there to give us the suspicion there are probably more genes there, because you see higher number of women diagnosed of breast cancer while there is nothing in the background. There is some genetic disposition of that. And when you investigate, then you find that those women, even especially at younger age, they do hide something. And of course, from the prevention point of view, is better to diagnose that genetic background at early stage, if possible, before we diagnose the women with breast cancer. We intend in these years, most overall, to do the diagnosis of breast cancer first, and then to organize a genetic testing. This depends on different factors, but even in big conferences where we discuss this option, we now want to try to give that understanding to the surgeons and choose wisely how those patients can be organized for more testing, because that 5% of genetic background of breast cancer, I think it's from what the evidence show, is higher. In other words, now we have to review the guidelines regarding organizing genetic testing on family history patients. And it's more or less, we in the group of choosing the patient wisely. Now, if I carry on a little bit, I mean, you are familiar with all this. I'm not going to analyze regarding age and where is the age of breast cancer more. After 45, we see it more. But what happens in the last years, yes, we have all the tools, all the advanced medical oncology treatments to the breast cancer, but even if we manage to actually say confidently you can treat it, we still see a number of young women to be diagnosed with breast cancer. And we also see a lot of people who are out of this group of risk factors to be diagnosed with breast cancer. So now we come to the point to accept and recognize the environmental factor. It's more or less a toxic environment that we live in, and again, wisely should be considered. Other risk factors, as I said, the paradox which I just mentioned is that absolutely healthy women come to be diagnosed with breast cancer. So this is something that also can be into that group of the genetic variants that are out there and we don't know, and also environmental factors. Most of the symptoms that a woman will complain, women now are more or less we try to raise the awareness, make them understand what to look, what symptoms they need to worry, and come forward to be examined. And anytime a woman has problems, they should come forward to be reassured and go through investigations. Of course, the most frequent complaint is breast pain and lumps. Lumps we see a lot for that we need to investigate, and some of them they end up to be cancerous. Lumps that are suspicious under the armpit need to come forward. Changes in the skin, any type of change of the color, of change in the shape of the breast, around the nipple areola, itchiness as well, breast pain, nipple discharge, all those symptoms need to come forward and be examined. Women should not be afraid anymore to come forward and be examined, because reassurance it's important to be given to them and relieve the anxiety, especially under those days that we live now with the COVID-19. This is another picture, gives you a little bit of the symptoms: an inverted nipple, that, or a redness in the skin, a puckering, or a nipple discharge, or a consistent, the breast feels a little bit harder than it used to, or change in the shape, or sometimes the breast being lifted up and they think, oh, it's something, they don't understand what is going on. So all these changes in the shape of the breast should not be ignored. It should come forward and be discussed with a specialist. So all this is a teamwork with the screening, the organized specialized MDT team, advance in diagnostics that we have, the genetics and molecular biology, that's the new the tool that we have, the breast awareness. All has increased the survival rate, and of course our aim is to prevent. Our aim is prevention in breast cancer. A little bit of information regarding, following some studies, and I look at, it's been always, I mean, to my experience, I've got a long experience, but most of the times we used to find out that the left breast is more common than the right, breast cancer. And I was wondering from my all this time trying to find out reasons that why that happens. Apparently, I found a study in the past that it's been proven, and I can show it to you here. But actually, I can't explain, and there are not that many studies. There are different explanations regarding that woman. For instance, use the detergent with the right hand. Women can use it on the left more, so more portion is. That's why we somehow try to teach women on the breast awareness to avoid chemicals. Now, this is a picture where it shows you the topography of the invasive tumors. The location where most frequent you see, if there is an area in the upper outer of the breast, is the more frequent where your diagnosis of breast cancer is. The other areas are less, but all of them, it's when a woman comes to the breast clinic for examination, when they go for imaging and they complain for certain symptoms, it's not only the upper outer, because it's most frequent and their symptom is located there. They should be examined for the breast as a whole, and the axilla as well. Axilla and the breast comes together. And this is for the in situ. Again, we see the location at the inside, also in the upper outer quadrum. A little bit of the facts from UK is actually more than 50,000 women were being diagnosed in the last years. This depends on the year that we look at, but since 2016, if I remember correctly, this number has been increased a little bit. Breast cancer is also present in men, and it's about 1% of all breast cancers, of women cancers. So per year, we might diagnose about 400 men of breast cancer. As I said before, we see a number of women under 35, and it's actually the women under 35 is the most common cancer from other type cancers. It's the most common is the breast cancer, and the number of deaths is still high. And from the age of 35 to 54, as you can see there in the slide, is the most common death of all, from all deaths, the most common is 70%. this is a normal breast, and this is the duct, the milk duct with the epithelial cells that you can see, but this is the normal picture. Now, what happens in the breast cancer from those cells? Normally, a cell should grow, divide, and get old and die. When what happens in the breast cancer, one of the cells, for some reason, for some type of insult that has caused the problem, the defect here, can start a continuous proliferation and can cause the uncontrolled cell growth that forms the mass and the tumor. Another statistic regarding European Union that everyone can look at it and find a little bit of this information. 5% of deaths among women is from breast cancer, 15.6% of deaths of breast cancer in women from all cancer deaths that was in 2016, and the incidence of men, as I mentioned early, 1% of all breast cancers worldwide. This is an example where the lobules and the ducts, from where the tumors, the most the two of the types of tumors that you can we know, the ductal and lobular, an anatomical picture and illustration here. And now we go to the types of breast cancer. Breast cancer, we do get diagnosed more and more types of breast cancer. But the most common that we know is the ductal carcinoma, the invasive. First of all, we divide it in invasive and non-invasive. As you know, the ductal carcinoma in situ and lobular carcinoma in situ is the pre-cancer stage. The early stage is not an invasive cancer. Then we have the invasive ductal carcinoma, with the most common up to 80%, with other subtypes that we have recognized, and the invasive lobular carcinoma up to 15%. Now, the invasive tumors in the latest with the latest biological and molecular staging is somehow divided in luminal A, luminal B, and that indicates luminal A, the highest strength in hormonal receptors. The lower strength of hormonal receptors are in the group of luminal B and on the receptor HER2 negative. Now, those are the invasive tumors. They are now classified as luminal A, luminal B. And I'll tell you later on what that means, because that also helps later on in the treatment. So the hormonal HER2, the human growth epidermic receptor 2 ends up to HER2 positives are 15%. Then we have the basal cells, another 15%. In most hereditary, in most genetic positive breast cancer gene 1 and 2, we see a lot of women having triple negative breast cancer, and at younger ages. In the evidence also shows that more common is in the Black women. We have the mixed tumors, inflammatory cancer, and Paget disease around the nipple areola. And the less common, but is still present, especially we can see that in young women, papillary is more in older, but phylloides and angiosarcoma. Phylloides still is uncommon, but still present. It can be quite aggressive at young age. every type of breast cancer we diagnose. And this is what is in the stages, in the clinical approach, in the clinical stage, because the patient comes to you, you have to prepare investigations. If you find a suspicious area, a patient goes for a biopsy. So once the biopsy is coming, they will give you some information regarding the type of the breast cancer we face first, and few of the markers from the core biopsy. So all that information in the first stage, the patient give us in the first investigations, it belongs to the clinical staging. So once the biopsies be done and sent for histopathology, we intend to clarify what type of cancer, the grade of the cancer. We manage to say the grade, but although the grade at a later stage after a surgery can change, but that's something that we have to inform the patient, or when we give the information of the diagnosis and what we plan to do. Now, the receptors, the markers that we get with the core biopsy are very important. And as you can see here, you have the hormonal receptors, estrogen and progesterone receptor, the human epidermic growth factor receptor 2, which now in the last 6 months and in the last, since the San Antonio conferences, those HER2 become HER3 and HER4. So we have more information about those receptors. But for us, when we do the core biopsy, this is something that we get from the core biopsy and can get it together with the hormonal receptors. Now, once we have the information of the imaging and the histology result, everything takes back to the multidisciplinary team. Your multidisciplinary team is your teamwork. Breast cancer does not work without multidisciplinary work. It's a multifactorial modality that not one science, is multi-sciences to give you the result and the treatments we have now, and the same way we carry on. So this is a multidisciplinary work. We have this result as the first step, and we take it further to organize treatments. Now, the type of breast cancer, the grade of breast cancer, and what the image of the lymph nodes in the axilla, we can have it in the beginning. Maybe if needed, if need to be done, we can do the fine needle aspiration on the axilla. So we have, and the first step, the first clinical stage of the breast cancer to take it forward and organize the next step. Pathologic staging is a completely, we cannot do it in the first step. A pathologic stage comes later on after surgery. Now, as you will see following to this slide, what staging on the staging, clinical stage, anatomic stage. Anatomic stage was up to now, up to a few years back, where we had the Nottingham Prognostic Index. This is a type of anatomic staging, and this is only given after surgery because you have to put the number of positive lymph nodes in the you have. So all the anatomic staging is given after surgical treatment. Now we come into talk a different approach on the staging, and we have the prognostic staging, and what's all about that in the anatomical staging, we can take this tumor, go further and analyze and do the gene mapping. And that will help to tailor what's the best treatment after surgery for a woman to have. And before a woman comes to surgery, if needs to have another treatment, it will be decided at the MDT. So once we have the clinical staging, we approach the MDT to discuss our case and decide what treatment will follow. There are certain cases that they need to go for neoadjuvant chemotherapy, and that will be clarified following the information we get from clinical stage and the MDT. So once you organize and you tailor the next step, the next stage of treatment, which will be if the treatment needs to be surgical, it needs to be if we need for the case to have neoadjuvant, or if we go straight forward for surgery. That will be clarified once you have your clinical staging and discuss your case with your team, your multidisciplinary team. This is also a little bit of information in view of the staging. For the in situ ductal carcinoma in situ, we have stage 0. We don't talk about staging. We have grades on ductal carcinoma. And for the invasive tumors, it's the stage 1, 2, and up to 4. This is the molecular testing that now it makes a big change in the staging and in the treatment of breast cancer. A lot of times in the past, we had a large size of tumor and we were taking this direct to chemotherapy. That once it's not absolutely necessary now, why we know the type of the cancer we have, especially the grade 2 cancers and hormonal receptors positive, but in the weak side of hormonal. In other words, we take those luminal B and we analyze with the Ki67, especially now with COVID-19, Ki67 is very useful tool to decide if we send this tumor we have for further gene mapping that will tell us if the patient even is large size but grade 2 on hormonal receptor positive and HER2 negative as luminal B if they need to have chemotherapy. If Ki67 is high, then that is going for oncotype score. That is a gene mapping, and that studies about 21 genes and has a high grade, medium, and low grade. And according to the result, we organize. If it's high, then patients go for chemotherapy. So that's where we're talking about now that the size of the tumor is not matter anymore. So big sizes it's not absolutely the indication to go for chemotherapy. But there are other molecular markers that is calculated on. Again, the multidisciplinary team is the one that will review what you have after the treatment that you organize. If it's surgical treatment, then will be, and if it's what type of surgery will be decided. The surgical treatment is conservative, breast conserving surgery. You try to avoid mastectomies. It's well established from 85 that there is not much difference in survival. The breast conserving from mastectomy. So following all the information we have. With the MDT, we'll decide what's the best operation for our patient, and we try to do breast conserving surgery. When you have an invasive and you go for breast conserving, always the axillary, the surgery for axilla, it goes together for this, that's part of the staging. Now, once you complete the surgical treatment, of course, the MDT will decide what the treatments will follow, chemotherapy, radiotherapy, or if it's what depends on the markers, what markers are positive, or targeted therapies or hormonal therapies that they have been established. They are all follow in a certain manner according to what we have in front of us, according to the age of the patient, according to the grade of the cancer, to the type of the cancer that we have. And the most advanced that we look now is immunotherapy, but this is not as yet uniformly established, although there is a lot of work and shows positive results on immunotherapy, and already some places they tailor the vaccine according to the biology of the tumor, which is very interesting, and we aim to get to that stage everywhere. Now, part of the treatment, if the patient is going direct for surgery, and as I said, we aim to do the breast conserving surgery. And the main point is always important in breast conserving surgery to organize your surgery to make sure what you choose, you have clear margins of the tumor that you want to take off the breast. We aim to go ahead and do breast conserving on the oncoplastic surgical treatment that will maintain the cosmetic results, will maintain the function, and have also good oncology outcome. It's very important to choose the operation, because once you choose an operation for the patient, if you choose, you need to make sure if it's an oncoplastic procedure, you need to make sure that your margins will be clear. If a margin is involved, the patient has to go back and have some more surgery, and in certain case ends up to have a mastectomy. Always important to see what oncological results you want to achieve. Prepare and discuss with your patient. This is the most important of all the steps before you take the patient to surgery or to whatever treatment you do, you organize. If the patient goes for neoadjuvant, still goes through a preparation. Anything you do, because obviously breast cancer treatment has stages, and the patients, once they understand they have to go through those stages slowly to get over breast cancer, they are more positive. They keep the positive attitude. They keep the positive way of looking at things for which is better for them. So sit with your patients, look what the diagnosis is, discuss the plan that you organize with your multidisciplinary team to proceed forward, and explain to the patient, and see also discuss with the patient, see what her expectation is important to understand, and explain every step of the operation and the procedure that you plan to do for her treatment. And all that aims to clear the good oncological result, to clear the tumor, to clear the cancer. Oncoplastic surgery gives you good cosmetic results. If you choose it right, most of the oncoplastic procedures and the mammoplasties, according to the evidence, give higher rate of clear margins. And margins is very important. Whatever you do in breast surgery, you see what procedure you're going to follow, estimated the volume of the breast cancer you're about to take out. If it's a small volume of breast cancer, you don't need to do a complicated oncoplastic procedure. That you can do a wide local excision. And of course, if you need to localize the area, there are certain ways to be done. And if you treat, you also need to understand you're going to go ahead to do the sentinel or axillary surgery, axillary staging, and you need to prepare the patient for that. All the invasive tumors, when it's wide local excision, or most of it's, when you say wide local excision for invasive, automatically you mean that there is also axillary surgery. In non-invasive, only in high grade of DCIS, sometimes we intend to do the sentinel, but axillary surgery. But all invasive tumors, wide local excisions, go standard with axillary staging. So you need to prepare and do the sentinel lymph node biopsy, and there is a certain way that you learn to do it, and there is the standard way we approach at the moment is by using the radioactive injection with the blue dye. In certain centers that they have experience now doing only the radioactive, but that comes with experience. But since '92, when we were doing the sentinel, we started with the blue dye, and then most of the centers now they do with the blue dye and radioactive injections. So when you do the you organize for a wide local excision, it's very important to organize how the surgery goes, explain to the patient all the steps, prepare your patients at all time, give all the understanding what you do with the axilla, why you do the operation in the axilla, why you do those 2 extra injections, you have to prepare the patient, all these preparation, and make patient understand what you're doing. As I said, breast conserving surgery is also a tool for you to avoid mastectomies. You don't need to do mastectomies as a surgical treatment. It's study your case and do the mastectomies only the cases that are needed. When you approach to do an incision on a patient, important to know where is your tumor sitting, which side, which quadrant of the breast the tumor sits, what the type, of course, but also is to understand what type of breast you deal. Your surgery can be dictated with the type of breast you have in front of you. If it's a very dense, small size, dense breast, you have to do certain procedure, different approach. The amount of tissue, again, as I said, is very important. If you have a large size of breast that is 20% of size of even more, up to 50% in a large breast, you can take it with no any oncoplastic procedure. So up to 20% volume of the breast, if you take it, is okay. If you do it on the appropriate way, then it will not be a huge defect. Again, underline topography, the volume you have to take out, and what sort of breath you have to deal with. It's very important. Those things are very important. Localization, know what you do in the topography that you deal with. You divide your breath in 4 quadrants: upper, outer, upper, inner, inferior, outer, inferior, inner. There is one upper inner quadrant that you need to be always aware. You cannot just cut that area. You have to approach in a certain way that you know to not to create huge defects. Remember those lines. We learn it since we were a student, and those are very important to remember. It's an example here with longer lines and where the incision. Look at this at the inferior half. You never do this incision. Okay, this also is the area that you have to be very careful how to approach. But this should not be accepted. So inframammary incision is the one who I do now. And periareola, minimal invasive surgery in breast, indeed. And this is that where is most of us, we do now, according studies we do, the breast we have in front of us. So we have the periareolar axis of minimal invasive and therapeutic mammoplasties and mastopexy. Binary mammoplasty is a technique that you need to know, although it can help you take more than one tumor from the breast. Now, when every procedure, when you take breast cancer out of the breast, you create a gap, you create a volume that is missing. This volume needs to be filled up by rearranging volume displacement. You can do it in a certain way. Or if you have to replace that volume, that means a flap. That's it, takes you to a different approach, or an implant. So breast surgery has much more, and according to the time you gave me, I will stop here and hear your question. As I said, following Marie Curie's one quote, nothing is to fear in life once it's understood. And this is not only for us, doctors, scientists, but for our patients. That's very important to make them, reassure them, and make them understand that we can help them. And we can help them to go through that marathon they are getting on once the diagnosis of breast cancer to them. There is much more that anytime I will organize another meeting, but if I carry on talking to you about, it will be much more time. So I'll stop here and take your questions.
Thank you so much, Professor Zoe, for this nice presentation. It was extremely fruitful and beneficial for all of us. Before we are moving to Dr. Dina, I have a lot of questions from the audience for you. I have to take some questions, then we will delay the other question for the at the end of the post presentation. One of the questions from the audience, she is asking you about the update in the clearance of the axillary nodes.
Okay, now, as I said, when we diagnose invasive, when you do the clinical assessment, you have to do the ultrasound of the axilla. So you have an idea if you have a normal axilla at your clinical stage, or if your axilla went for fine needle aspiration, because on the ultrasound, it looked as suspicious thick cortex on the lymph node, so suspicious lymph node. And it was, if that's from the first stage, then the radiologists, the specialist breast radiologists will go ahead and do the ultrasound guided biopsy of that lymph node. Once you have the result of the histology altogether, let's say take the scenario that this lymph node is negative. The invasive tumor that you're going to take for surgery as a wide local, let's say, for example, conserving surgery, goes automatically, is standard procedure, a sentinel lymph node biopsy. If it's negative, as I said, if that biopsy that she had with, even it was looking in the ultrasound suspicious, but in the fine needle aspiration comes negative, right? So you have two options in the first stage. You have a normal ultrasound of the axilla, or even if she went for fine needle aspiration, it might come normal. Then all that goes direct for sentinel lymph node biopsy. Now, if the axilla is positive in the clinical staging, then is axillary clearance.
Okay, thank you so much. I believe we, Dr. Yasser, have introduced both of our panelists today, Dr. Islam Khalid and Dr. Amr Safat. I believe Dr. Islam had a certain experience in addressing the sentinel lymph node. Dr. Islam, do you prefer to do it in a double identification using patent law and radioisotope, or you are depending only on one method of identification for sentinel lymph node?
First of all, I'd like to thank you all for this wonderful scientific presentation. My experience regarding the sentinel lymph node biopsy, which I believe is one of the best techniques to avoid the complications of axillary lymph node dissection, especially in early breast cancer, which is about 80% of those patients who are in early stage of breast cancer is completely cleared from being harboring metastasis in their axillary lymph node. Regarding the route of identification, I believe the double technique is the best one to get an accuracy reaching about 90 or 95% for diagnosis of the axillary sentinel lymph node biopsy.
I'd like to add to this.
Thank you so much, Dr. Islam. Professor Zo, what about the axilla that was positive and turned it into negative after upfront chemotherapy?
Yes, let me just take you a little bit more about the axillary surgery, which can be another talk, because the axillary surgery is a big topic, especially with the updates that we have in the last few years. And we don't really we try to avoid the axillary clearance if we can. According to evidence, according to our studies, but there are selected cases again, because of course axillary clearance has a high mortality and morbidity rate and a lot of complications later on. So what happens if you go for the sentinel lymph node, and okay, depends on the technique you use. If you want to use it both, of course, I have to say that on evidence again, blue dye and radioactive has more accuracy and less false negative. Now, in this, there are some studies, very interesting studies from Japan, that a lot of surgeons think that one sentinel lymph node is enough. Well, you might be the best to even point with anatomical location where that sentinel lymph node. You know anatomy, you can point it, but evidence on studies about, especially from Japan, indicate that actually the sentinel lymph node is not just one. If you do that study, Yamamoto, I think is under that name, indicates that there's more than just one sentinel lymph node lying there. So it's very important to do both techniques and actually try to get up to 3 lymph nodes. And you will see that if you do both techniques, if one is radioactive strong, the other two will be both radioactive and blue, or blue, and you will see that all they are, so it's better all the time for your patient. Aim not just to take just one lymph node. Try to see if you do both techniques. I reassure you, you can find more than one.
Perfect. I have another interesting question about about the quality of life post cosmetic reconstruction for the breast after breast cancer surgery. Does the quality of life improved after oncoplasty, in your experience, for your patient?
Oncoplastic procedure, so oncoplastic surgery is the standard surgery approach nowadays. I work in UK, but in USA, wherever else, this is what I learned, and this is what I've been doing even before I come in England. In Greece, we were quite advanced doing a more oncoplastic procedure there. So the quality of patient is very good, and the actual patient, the patient feels happier because it keeps the shape of the breast. If you need to symmetrize, because sometimes the volume of one breast, even if it's cosmetically, it's good, but the volume, it might be smaller, but you can do at a later stage and put a symmetry mammoplasty on the contralateral breast to make the woman happier when she wants to go ahead with that. But that you don't, sometimes some women want to do it at the same time when they do the first operation. Something which other women, they prefer to complete their treatment and later on go for whatever they need to do to add later on. So the result of cosmetic surgery is very good and the patients are happier.
Yeah, I believe that we have in this platform and this webinar one of the most eminent plastic surgeon in the area. Dr. Amr Safwat is our professor and is our colleague here in SGH. You know, in SGH Gadja, we have this multidisciplinary approaches for surgical oncology, me and Dr. Islam, and plastic surgery, Dr. Amr and Dr. Dina, for post-operative pain. I would like to hear about the experience of Dr. Amr for that specific question. Do you believe that oncoplasty and the plastic reconstruction of the breast affect the quality of life of a patient with a breast cancer?
Unmute, Professor Amr, please. Unmute.
Unmute. Dr. Amr, your mic is muted.
I'm okay now?
Yes.
Can you hear me now?
Yeah.
I'd like first to thank everybody about this fine webinar and fine presentation. Actually, in the old days, we didn't have what's called oncoplastic surgery, and the patients just had their mastectomies. And there was the reconstruction after a mastectomy, and it was a very harsh issue. The patients don't know whether they are cured or not, the recurrences will be there or not. And actually, with the development of surgical techniques and understanding and cosmetic procedures, okay, you will not have the reconstruction immediately, but at least when we do the excision, we do it in a way not to mutilate the partially excised breast. Because when we started the area of partial excision, breasts were very much deformed and it was very much cosmetically unacceptable. I have seen one of the questions about the impact of the cosmetic surgery and the quality of life. Definitely, it improves the quality of life and the way the patient feels about herself when she looks in the mirror. She can see a breast or she can see something which is nice looking. It might not be like the other breast. And as Dr. Joy said, the symmetrization surgery came to the practice afterward. But definitely, cosmetic surgery, it's having a very large role, either in the beginning now, in the oncoplastic sense, or after we do whatever we have done, we can do a reconstruction and we can have an almost normal looking breast, especially with the new techniques of nipple sparing, areola sparing, skin grafting, tattooing, and skate flaps. We can have a very good, normally looking breast.
Thank you, Dr. Amr, so much. I believe actually if we have a happy woman after getting off her tumor, this will affect the overall result of the treatment and will improve the survival and the whole result of the treatment of the tumor as a whole. Yeah. Now we have to move. I'll make the list the other question at the end of this webinar. No, we have to move to Dr. Dina. Dr. Dina she's our consultant of pain in SGH Gadda. Dr. Dina, one of the eminent pain consultant in the Middle East. She's a professor at National Cancer Institute, Cairo University, and she joined our SGH hospital 3 or 4 months ago. And we are pleased to have her among our team for comprehensive breast services. Dr. Dina, it's yours.
Thank you, Dr. Ehab, and thank you all for inviting me to join this marvelous webinar. I wanted to share my slides.
Please.
Okay.
Yes, perfect.
My talk will be
Excellent.
about post-mastectomy pain syndrome. I cannot, I don't know what is happening. Post-mastectomy pain syndrome is not a specific diagnosis. It is a cluster of symptoms that observed in breast cancer survivor. Actually, it is a misnomer that can be seen following mastectomy, lumpectomy, lymph node dissection, reconstruction, as well as chemotherapy and radiotherapy. This is a common scenario. We find such a patient complaining of mastectomy 6 months ago, and she has chest wall pain at the surgical site, tingling, burning sensation, shooting pain in her upper arm, and she is cancer-free. Another scenario, we can find such patients complaining of burning pain up to 10 years after radiotherapy, and she is cancer-free. The prevalence of post-mastectomy pain syndrome is very common, from 20 to up to 57%. Severe cases range from 5 to 10%. Neuropathic pain from 56% of post-mastectomy pain syndrome. The causes of pain can be due to phantom breast pain, intercostal neuralgia, neuroma pain, musculoskeletal pain, peripheral nerve dysfunction due to surgery, radiation, neurotoxic drugs, or chemotherapy. There may be shoulder adhesive capsulitis up to frozen shoulder and complex regional pain syndrome, or what is called causalgia. Actually, it is a disease by itself. Chronic post-surgical pain syndrome is a disease by itself. Cancer-related pain is a disease by itself and has a ICD code. And it has its right to be treated. The IAS specified this year to be the global year for prevention of pain. This prevention of pain can be primary prevention to protect against the onset of pain, what is called protective pain, or secondary prevention, prevent pain from becoming chronic, or tertiary prevention to reduce the long-term consequences of pain, unmanaged pain. But why only some patients develop chronic post-surgical pain syndrome? There is prediction of acute post-operative pain, patient-related factors and surgery-related factors. Regarding the patient factor, it is more common in younger age, smoking, history of depression, catastrophic event, anxiety, sleep disturbance, body mass index, higher body mass index, presence of preoperative pain, and presence of preoperative analgesic use of drugs. So once we predicted such patients, we should deal with them in a different way. Actually, this is the job of the surgeon, and this is the job of the anesthetist in the preoperative assessment. When we find patients has predictive factors, they should be dealt with in a different way. They may be sent for psychotherapy or rehabilitation in a sort of preconditioning. Such cases will decrease the occurrence of post-operative pain and the chronic post-surgical pain syndrome. Post-surgical pain syndrome is a warning sign. Not all patients require the same doses of drugs or the same analgesics. We have some patients always seeking of opioid or seeking of analgesics. They should be treated in a different way. And this is the right to be treated. Prevention of chronic pain after surgery by using drugs and regional analgesic techniques. As we know, in the world, there is opiophobia, and all measures should be taken to reduce the consumption of opioid. There is a Korean database study recommending regional anesthesia for chronic post-surgical pain syndrome, and the use of intravenous local anesthesia infusion for prevention of post-surgical pain syndrome is highly recommended. Some drugs show best result with the prevention of post-operative pain, but actually they didn't show good result in prevention of chronicity. One of them is ketamine. Pregabalin is recommended to be used for prevention of post-operative pain. Lidocaine infusion showed a good result in prevention of post-operative pain and in prevention of chronicity. Now we have to reframe the pain. What can we do? For prevention of post-mastectomy pain syndrome, there is recommendation of use of combination of drugs, for combination of regional anesthesia and the drugs, and treatment to be tailored or individualized for each patient. Together with biosocial approach for such patients and the multidisciplinary approach. The ERAS concept now, or enhanced recovery after breast surgery. There are many approaches to recommended for rapid discharge of patients from the hospital. Preoperative fasting, preoperative anxiolysis, anesthetic protocol recommendation, ERAS recommended anesthetic protocol for breast surgery, intraoperative warming, pain controlled and analgesia, prevention of postoperative nausea and vomiting, antibiotic prophylaxis, anti-DVT prophylaxis, surgical drains to be removed early, mobilization, postoperative discharge support. ERAS anesthetic recommendation. There is recommendation preoperative, intraoperative, and the postoperative. Preoperative, the use of paracetamol and the non-steroidal anti-inflammatory drugs. They have grade B evidence. Gabapentin, grade A evidence, dexamethasone, and local anesthetic infiltration of the wound. And the postoperative, to use paracetamol, non-steroidal, and opioid are used only as a rescue analgesic. This regarding minor breast surgery. Major breast surgery are the same, added to them PEX block or paravertebral block. So for prevention of pain, we can do prevention preoperative when we screen patients who are vulnerable to develop chronic pain, and there is early prevention, when we screen patients who are seeking for opioid, are not controlled, their pain management are not controlled in the first day of surgery, these patients should be dealt with in a different way. And patients who have psychological depression or catastrophizing events. So we have preoperative risk factor, intraoperative risk factors, and postoperative risk factors. As mentioned, the patients who are in pain preoperative are likely to develop pain postoperative. Psychological vulnerable patient, young age, preoperative use of opioid. Intraoperative, when we know there is nerve damage during surgery, these patients should be dealt with in a different way. Postoperative patients, when they have pain score more than 4, there is sensory disturbance or neuropathic pain, when there is surgical complication, redo surgery or repeated surgery, psychological vulnerability, and the postoperative need of opioids. These patients should be dealt with in a different way. How can we manage such a patient? We cannot send them on opioid drugs. This is not a solution. We can develop a model to treat such patient by cooperation of the anesthetist, the surgeon, and the acute pain service team, together with outpatient pain clinic, to develop a multidisciplinary approach for such patient. This workflow can start with the nurse. The nurse play an important role in communication with the patient and the psychological reassurance. Her role can begin preoperatively, and she can play an important role in the postoperative period, even after discharge of the patient, by phone number, to ask her about the pain and the opioid, and to ask her some psychological or questions. And these patients are asked to come to pain clinic to monitor their drugs and to try to do opioid withdrawal, and send her for psychological support and prescribe other drugs. This is some protocols can be used for pain management, and I'll stop right now. Thank you.
Thank you so much, Dr. Adina, for your interest topics. I'd like to address one of the questions from the audience. She asked about her pain. She had a mastectomy, and she still have a pain in the axilla on and off. Is there anything to make this pain disappear?
Yes, we should do proper diagnosis of this pain. Is this pain neuropathic pain or musculoskeletal pain or frozen shoulder? It should be analyzed well and treated in a multimodal drugs in the form of anti-neuropathic drugs. Some blocks can be helpful for such patients if there is fibrosis, with Botox injection, rotator cuff injection. Sympathetic blocks play an important role for some patients. Stellate ganglion block, thoracic sympathetic block can play a role. Actually, the management is multimodal.
Thanks so much, Dr. Adina. Dr. Zhu, did you experience such kind of pain post-mastectomy in your patient?
Well, the pain after mastectomy could be immediate or delayed. So again, it's very important what Dina mentioned very well, analyzed the approach: preoperative, intraoperative, postoperative. Those steps, initial steps for any operation, it counts. It's very important. See your patient, know your patient. See that when you sit with the patient, you'll understand. And then, of course, you need to know the background and past medical history, and try to minimize the medications for later, in sense of try to do the intraoperative approach by doing some blocks if you can. If your anesthetist is knows to do some blocks, that will at least help the patient to avoid that post-operation surgery, the immediate pain. And from what I study, I look at about 10 to 15% of post-mastectomy pain becomes chronic. Most of the patients, if you use certain techniques and also get to know your patient and do what you have to do pre-op and intraoperative and post-op, they don't get much pain. A lot of patients get from out of the hospital the same day, so they don't have that severe pain. The delay post-mastectomy pain can be a problem, because that could be related to scarring, and especially if they do get extended axillary surgery, then they do get pain that needs to, as Dr. Dina said, it needs to be again studied and has multi ways of approach and applications, and alternatives methods also can help in the pain management, that it will be delayed.
I have as well.
Yeah.
Actually, we noticed when we did the reconstructive surgery, trams or DIAPS or anything, when we did a very good block and the patient recovered from the surgery without feeling any pains and started to develop the regular post-operative pains afterwards, those patients never complained of a chronic long-standing pain. But if we missed the blocks or missed the local infiltration, and the patient starting complaining of a certain type of pain immediately after the surgery, we noticed that these patients usually have it in their minds. It's not having like a solid basis or evidence thing, but it's a remarkable thing to be said. We have seen it in so many patients. That's why we are used in where I used to work in my centers in the UK, that we put a very important emphasis on having the blocks, and most important thing, that the patient doesn't feel any post-operative pain by any means. And this actually helped a great deal.
I do agree completely with you. I do agree with that.
Yeah. I have another question for you, Professor Zoe.
Yes.
It's about mama print and oncotype. The audience is asking, is there any specific genetic test you prefer according to your experience, whatever the patient criteria or whatever met the patient criteria?
Okay, if we, as I said, it's a low grade, grade 2, most of the early cancers with hormonal positive, hormonal receptors, estrogen receptor, progesterone receptor, and HER2 negative, that they do have a Ki67. Ki67 is a good marker to monitor with your medical oncologist, because as I said, all this goes under medical oncologists. Once we see with the first, most depends on in UK, for instance, we do have oncotype. Other places, they do use mama print. And the problem was, if you have intermediate score of oncotype, that was the talk, that they were uncertain what we do with the intermediate. And they've compare that intermediate score of the oncotype with the mama print. Mama print is binary. It has a high and a low. So half of those intermediate go to the low. So it's a good sitting with your medical oncologist, see the type you have, study your case and the histological grades and the histological markers you have, and you decide that the oncotype DX is the first one we sent here. And then if you want to do something more, you always can, but depends on your medical service you have in your hospital. If you offer the mama print, fair enough, you can send it for mama print, but the oncotype is the first approach we do, and it gives you a good result, gives you an answer.
about male breast cancer, I believe Dr. Islam, he operated upon one of the male breast cancer this month. The question, how frequently you are seeing male breast cancer in your practice, Dr. Islam?
I cannot hear.
Dr. Ihab, you may repeat لو سمحت the question.
I didn't hear
we have a course to do. It's about breast cancer, male breast cancer. How frequent you are seeing male breast cancer? I took Islam in one of our he operated on male breast cancer this month. That's why I need to hear from Dr. Islam. How frequent breast cancer in your practice in Saudi Arabia?
Okay, so now I repeat. So because I don't hear very well, so I repeat. So you asked me to tell you about male breast cancer, how often it is, and tell you about this, right? Correct?
Exactly, yes. That's what he said.
Yes, okay. Now, as I said, in every patient you have, it's important to get the background. And in the prevention setting, we always try to make people aware to know their background, know their family history. For women, as I said, every past medical history, if they have a previous breast problem. For male, there is, as I said, 1% number of breast cancers in male in the entire number of breast cancers. In all the breast cancers, there is about, like for instance, 400, when I mentioned about 400 number 400 of male breast cancers that we approximately see in UK, it's in the whole number, all number diagnosed of breast cancers in 1% per year. So there is for male. They have to know their background. In other words, if they have a strong family history of breast cancer, if their mom or if they had other male in the family who had breast cancer, or if they have a family history that there is circulating the breast cancer genes, they should be aware, and they should, if they have any symptoms, they should go and to discuss their problems all the time, because indeed there is a risk for male breast cancer. And it's very, very important to know their family history. For them is relied on their family history more than anything else.
Okay, I believe Dr. one of our oncology consultant in MGH, he had one of his patients with a male breast cancer this month. I wanted to ask him how frequent you are facing the disease in Saudi.
If a man's come to the clinic with a lump, let's say a lump, and been diagnosed with a triple assessment as positive, then we know the biopsy result, what sort of grade it is. So most of the times the patient goes direct for, depends also, we have to organize if it's a positive axilla, negative axilla, do they go for sentinel lymph node or do they go for axillary clearance, so as the first stage. So, but the majority of them, we take the whole, they go for mastectomy. There is no much breast tissue for them to be left behind. So what you organize, if you have a cancer in the breast, you need to know exactly what type of cancer you have in that male breast. You need to organize the procedure, this axillary staging, and if it goes for sentinel, or if it goes in the beginning for mastectomy, a sentinel lymph node and a lymph node comes macroscopically invade with breast cancer, it goes for later, as a later stage, another operation for axillary clearance. So the preparation of full preparation, triple assessment, know the grade, discuss your case, organize the surgery. Mastectomy there is no much to save there. So you do a mastectomy in all men breast cancer, but of course you choose what procedure you do for the axilla. If you go for, if it's a normal axilla, you go for a sentinel lymph node biopsy with a mastectomy, and you do the same approach, like you prepare for a blue dye and for radioactive injection. So, and then later on, when the result of histology comes after that, if it shows that it's a positive, now some centers here, maybe we talk another time about axillary surgery, because things have changed with Z11 studies and Z10 that's been since 90s. So if the sentinel lymph node shows micro invasion, micro, not macro, obviously, then if there are 1 or 2 sentinel lymph nodes that are micro invaded by cancer, we might we don't do any further axillary surgery, but do radiotherapy in the axilla. Now, as I said, all these applications, they don't apply for everywhere. Some people, they still intend to, even they have the micro invaded lymph nodes, they go ahead and do the axillary clearance. If there is a sentinel lymph node is macroscopic, macro under the microscope, micro invaded, so it's more than 2 millimeters, then it should be is going for axillary clearance even later on. And of course, after you stage the axilla, so you know what the axilla is, you know the final histological results. So always you have to define what the receptors you have positive, what are negative. You accordingly organize. Radiotherapy is most of the time standard procedure to follow after surgery. So depends on the hormonal status and the grade on what sort of the treatments will be organized after. It could be just hormonal with radiation. It could be, if needs, if any axillary lymph nodes are positive, might go more for adjuvant chemotherapy and oncological support. So it's all, for a male, it's mastectomy, it is, with what you decide to do for axillary staging.
Any role for neoadjuvant chemo?
Yes, there is a lot going on. And this is another huge talk about breast cancers, because now it's a new topic that they start discussing in San Antonio. And it's, do we actually need to do surgery in women who have a complete pathological response in neoadjuvant chemotherapy? This is a very fresh topic. It's been started talking at San Antonio. So yes, we have neoadjuvant chemotherapy. It's a standard neoadjuvant for the triple negative cancers. They go for neoadjuvant chemotherapy, and then for surgery. Of course, the size of the tumor matters. It's another sensitive point that you need to discuss with the patient, because for conservation of the breast, and it was what we used to do in the past, and we still do, to preserve and conserve the breast for more conservative surgery rather than mastectomy, we do start with the neoadjuvant chemotherapy. And the high grades, according to, as I said, all these triple negatives, they go for neoadjuvant chemotherapy.
And the reason I'm asking that, because we're doing more cosmetic surgery, immediate reconstruction with people who had neoadjuvant chemo. So now this is new to us, actually. We give neoadjuvant chemotherapy and then we do immediate reconstruction, because we're having like a smaller, a down staging, like we're going towards that direction. What do you think about that?
Yes, of course, yes. I mean, that's the aim also for neoadjuvant, but to immediate, you gain immediate reconstruction, you need to, if your everything is optional, all your parameters are optional to go ahead and to immediate reconstruction, of course, it is a good option, and you choose also what sort of immediate reconstruction you want to do. We'll do that, and it's something that is becoming more and more in practice.
I think we are, Dr. Ihab, we are running out of time. We exceeded actually our time with like 10 minutes. I'm sure that we are all enjoying the discussion and our panelist input. But I don't know if you don't have any other questions, we can conclude, please.
You can see Dr. Ihab. Where is he?
Okay.
Question. They look. There are questions.
Okay. Anyway, I'll take over from here. I want to really to thank Professor Zoe Vlamaki for her wonderful and comprehensive talk of today. I'm sure that we all were very interested for us, and we enjoyed the talk. I want to thank also Dr. Ihab Saad for moderating and coordinating this excellent discussion. I want to thank Dr. Amr Safwat, our plastic surgery and obesity consultant in Saudi German Hospital, for his input and contribution to the discussion. Dr. Islam Khalid, our consultant general surgery, and special thank to Dr. Dila Nabil Abbas for explaining the role of pain management in supporting cancer patient improvement of outcome and quality of life. I want also to appreciate all our participants for attending this webinar. And I hope that you enter your telephone number and your email correctly, so we'll be able to contact you. As we explained before, that all of our webinars are applied for Saudi Commission for Health Specialty Accreditation. Still, it's in the application process. There is some delays of getting the accreditation due to an issue in the portal of Saudi Commission, but we are working on it. We have so far 2 webinars approved and all the names were uploaded. Please, if you have any inquiry, contact us and we'll contact you back and make it really easy. We are going to upload all the names who registered and entered their proper Saudi Commission number. That's in 1 week time after the webinar. I would like also to ask the participant to fill the feedback form. The feedback is very important for us to improve our webinars and to have maybe to suggest more topics to include with Professor Zoe in the future. Professor Zoe promised us that she's going to conduct a series of webinars about breast cancer. It's part of her passion and mission, and we are sharing with her the same vision to establish really a breast cancer care in Saudi German Hospital Group, a multidisciplinary team of our distinguished plastic surgeon, oncosurgeon, pain management. That's our aim, to help patients really to have a better outcome and better quality of life. Looking forward to see our panels and our Professor Zoe in future webinar, and looking also to see our participant in our coming webinar, IVP webinars. We have coming Sunday also another webinar will be on. Thank you very much and wish you all the best.